We would like to welcome Dr. Rajiv Agarwal. Dr. Agarwal is an internationally recognized leader in the area of clinical and translational research in nephrology. He is a tenured professor of medicine at Indiana University School of Medicine and has published about 250 original papers and reviews in nephrology. We're happy to have you here.
Thank you.
Of course. Despite CKD being very common, its early identification and diagnosis is often missed. In your opinion, why do you think this gap exists, and how can it be better addressed to ensure early detection?
I think part of it is lack of awareness of CKD. People know about lipids, blood pressure, but CKD is not something people are looking for. All the guidelines have been fairly consistent that they recommend screening for chronic kidney disease once a year in people who have type 2 diabetes. And the screening involves two things. One is measurement of creatinine, so we can get an estimated GFR. The other way is to measure albuminuria, and that requires simply a urine test. The problem is people are doing the first part where they are measuring the creatinine and getting the eGFR, but not too many people are measuring urinary albumin, and they're missing the diagnosis many times. So I think that people need to recognize that the diagnosis of chronic kidney disease just doesn't rest upon failure of the kidneys to filter, but also the ability of the kidney to excrete more protein is also kidney disease. Once we have that recognition, I think people might actually start doing this more frequently, because now we have therapies that you can do something about it. It's no longer of academic interest. You can do something about it.
How important is it to address or screen for albuminuria in high-risk patients, especially with those with type 2 diabetes?
People with type 2 diabetes require both screening for albuminuria and creatinine annually, at least. And it is really important to screen for both. Now, the ideal test is to just do a spot urine, first morning void, and test it for both urine albumin and urine creatinine. If they did that, you have a perfect test. And we do it at least 2 or 3 times initially, so we know that they have persistent albuminuria. If that's not possible, then test urine protein, even dipstick protein, whatever they want. But if we don't have a diagnosis of proteinuria, albuminuria, or dipstick proteinuria, we are not doing our job. So it's really important to test. All the guidelines recommend it, but people are not doing it enough, so it's really important to do this.
And focusing on the management of CKD in patients with type 2 diabetes, how have guidelines and current treatment options evolved, and what are their clinical implications?
The guidelines have evolved because, 5 years ago, we were in a therapeutic desert. All we had is blood pressure control, lipid control, and ACE and ARBs. Subsequently, we have had multiple new therapies. Importantly, in 2019, the advent of the SGLT2 inhibitors, and in 2021, the non-steroidal MRA, finerenone, they came about. And now another pillar is cropping up is the GLP-1 RAs, which are undergoing clinical trials. They do reduce albuminuria. They reduce the risk of atherosclerotic cardiovascular disease in people with CKD, but we have to see whether they have hard outcome benefits in people with CKD. So we have a lot of options, and that's why it's important to start screening people for kidney disease, particularly when they have type 2 diabetes.
Absolutely. And in your opinion, how can we get past some of the current barriers for screening and treatment of CKD in patients with type 2 diabetes?
I think that the important thing is the recognition that it's no longer of academic interest. If you screen for albuminuria, it says you just don't go to the patient and say, I'm sorry, you got kidney disease. It says, yeah, I'm sorry you got kidney disease, but you have an option now to do something about it before your kidneys fail. And if you take this drug, for example, SGLT2 inhibitors, we reduce your risk for kidney failure progression by about 1/3. If you take finerenone, we reduce your risk of progression of kidney disease by 1/5, progression to heart failure by 1/5. If we talk to patients in ways that they understand the importance of new therapies, we can have embracement of these new therapies and perhaps change practice.
Well, we want to thank you for your time today, Dr. Agarwal. Do you have any other conclusions that you would like to add?
No, I think that really important thing is to screen for albuminuria and recognize that if we have albuminuria, it's a 911 call. We can't be just complacent about it. We have to modify the lifestyle, and on top of that, use ACE and ARBs, SGLT2 inhibitors, finerenone, and GLP-1 RAs. Thank you very much.